I would say the first that comes to mind that is deeply important and truly under the locus of control of agency leaders is to change the organizational culture. I think this is what public health practitioners who are not in leadership positions and that don't have the power to change the organizational culture,
Right,
that's what
right,
they crave.
right.
And that's what we heard. And that's why it's really our first recommendation. If agency leaders really believe this work is important, and are committed to doing it no matter what word we use to describe it,
Right,
but they
right,
are
right.
committed to those three elements that Dr. Jones talks about, then there's a way to do it. If there's a will, there's a way. Hello, everyone. I'm Dr. Jamila Porter, Chief of Staff and Principal Investigator of the Made for Health Justice Initiative at the De Beaumont Foundation, and you're listening to the Public Health Insight Podcast.
You're listening to the Public Health Insight Podcast, your go-to space for all things public health and global health, from the Sustainable Development Goals to the social determinants of health, as well as interesting dialogues about the diverse career opportunities that exist in these fields. Remember to subscribe to the podcast and leave us a rating on Apple Podcasts and Spotify so other people like you can benefit from our content. Imagine working in public health, knowing that racism is a public health crisis, but being told, that's not really your job. Now imagine that you're not alone. Tens of thousands of your colleagues feel the same way. So why is it so hard to turn good intentions into real change? Let's start with a number, 44,732. That's how many public health workers across the United States answered a survey in 2021 about the state of their field. And what they said? It's a wake-up call. From PHI Media, I'm Gordon Thane, and this is the final episode in our 3-part miniseries featuring two people who know this data inside out, Dr. Jamila Porter and Kay Schaffer. Dr. Jamila Porter is Chief of Staff at the De Beaumont Foundation and Principal Investigator of the Made for Health Justice Initiative. She's an award-winning researcher and a national voice on health equity and data justice. Kay Schaffer is a Research and Evaluation Officer at the Foundation who leads many of the Foundation's program evaluation projects and has managed the largest public health workforce survey in the country. Together, we're digging into the Public Health Workforce Interests and Needs Survey, otherwise known as PHWINS. It's the only national representative survey of state and local public health employees, and it's massive. Over 137,000 people were invited, and nearly 45,000 responded. The survey, plus in-depth interviews, reveal a system where most workers believe equity should be a priority, but for many, it's still treated as extra work, not the job itself. So what's really holding public health back from living up to its promise? And what would it take to change that? Let's find out. Equipping the public health workforce to advance health equity. You've identified some of those points of disconnection and pain points, dug a little bit deeper into the data to understand why some of those responses might have turned out that way. So what remedies do we have that are evidence-informed to get us to a place where we're having a public health workforce that's better able to integrate anti-racism practices and advancing health equity across the spectrum or continuum of public health? What would leaders or individuals working on the ground be able to take from the learnings that you've both worked to uncover to incorporate into their organizational practice? Because I understand you have quite a few very tangible, very specific recommendations. Some you could call low-hanging fruit if people use that word, and some are a little bit more structural in how an organization needs to be transformed. So can you talk a little bit about those?
Sure. So I'll start just by zooming out a little bit and just talking about what the impetus for even doing this research was and how it's directly connected to the PHWIN survey, but we collected the data in a different way. So what we learned from the 2021 PHWINs is that public health practitioners wanted to address racism as part of their daily work, but a lot of them were not directly engaged in this in any way. And so the question was like, why? What is behind that? What's driving the for practitioners who have so much interest in doing this, they're not able to actually operationalize this and do it in their day-to-day work. So what's happening? So between late 2023 and early 2024, we interviewed 20 public health practitioners across different health departments, different levels, local, state, and different regions, and asked them questions and basically conducted interviews with them to obtain richer information about this issue and ask them about what are the barriers that were preventing them from taking on racism as a public health crisis and addressing structural racism in their work, as well as what were opportunities that they saw for improvement. And so it's important to know that any recommendations that we came up with really came out of what we learned from practitioners themselves and in these conversations, which lasted upwards of 60 to 90 minutes each. So people were so giving of their time to share this kind of information with us.
But the real stories come from what happens after the survey, when researchers sat down with 20 public health employees for hours-long interviews, asking the question, what's stopping you from making equity part of your daily work? This is where the data gets real. The data shows that public health workers overwhelmingly want to address racism and inequity. But the system, it's not built for that. In fact, many told these researchers that equity work is seen as side-of-the-desk stuff, something you do if you have time, but not something that you're expected to do. And the barriers, they're everywhere. Unsupportive policies, political pressures, and leaders who talk the talk but don't walk the walk.
Some barriers that we learned that public health, like governmental public health employees were facing were unsupportive organizational policies and cultures, unsupportive political climates, which again, we conducted these interviews back in 23 and 24. So you can just imagine how that has really escalated even more now. A lack of action by department leaders to take on structural racism in a very explicit, direct way. And ultimately, we heard a lot of our interviewees tell us that work to address equity was really considered extra. It was treated like extra additional work, and it was not integrated into
Side of the desk work.
Right. It wasn't integrated into their daily core work. And so upon learning that, it seemed some of the recommendations that we make are directly connected to those learnings. Everything we make recommendations about making that health department executives and folks in leadership are directly responsible and influential of the culture of their organization. So they have to take direct action to not just, and that's where the title of the report comes from. So not just to talk about equity, and although there are many who feel that it's risky now to do that, there are many others who are still trying to stand up and do this work very explicitly, but we have to do more than just talk about it. We have to do it. I think the doing it is another thing that sometimes stymies folks, like, what is that? And I think a good start is looking at the way that Dr. Kamara Jones, who folks may know as a public health rock star, who also would be at the table if you let me have a fourth person, where she defines equity as three things: valuing all people and populations, recognizing and rectifying historic injustices, and providing resources according to need. So if you're doing those three things, you're doing equity work. And so I would say that can look a lot of different ways depending on who the population is, the community is, and what the needs are. But that, in a nutshell, is really what we're talking about doing, which isn't an incredibly new idea.
Yeah.
We also talked about how health departments should infuse principles of equity into their core work so that it's not extra, that we should be within governmental public health and in research broadly, I would say even academia, in organizations and institutions that are doing any form of research, even if it's not just in the university setting, but also within epidemiology and other public health practice-based data-related work. We should be measuring the effects of racism and the underlying causes of race-associated differences in health outcomes. So that means not just saying that this racial group has a difference compared to this racial group, but really because race is a social construct, it's not biological. It's telling us that structural racism is at play. And we need to understand what are the impacts of racism rather than just looking at surface causes, or not even causes, like just surface data statistics
Mm-hmm.
that are just categorized by racial groups, which is an arbitrary way to categorize people anyway. And then we also talk about other important factors that need to be at play in terms of our recommendations, that health departments should be collaborating with community partners, community based organizations, community power building organizations that do organizing work, that do grassroots advocacy. They are really at the heart of trying to support and bolster the work that health departments do.
Mm-hmm.
And it also requires us to work directly with communities, oftentimes through those organizations and even with residents themselves. And we call that is known as collaborative governance, basically governing
Mm-hmm.
collaboratively so that community members have formal opportunities and are decision makers that get to determine what is done in their communities and how it's done. And Kay, anything else? I know I talked a lot about different recommendations that we made.
I would just really double down on what you were saying in that political contexts might change, but the issues facing communities don't. And the ways that we need to address them remain relevant, salient, and more important than ever, which Jamila highlighted previously. I would also add that part of what we work on at the foundation outside of this work is providing public health communicators with better tools to do their jobs well and to communicate about the effectiveness of public health when integrated within various policies and other aspects of government where it might not be seen as a natural partner. Because part of what we found in our research is that public health practitioners aren't just public health practitioners or storytellers. They are who people turn to not only when they need evidence-based public health information, but for when they're trying to make decisions about their bodies and their communities. And equipping them to be storytellers that can not only convey scientifically accurate information, but really a compelling narrative is something that there's a real hunger for within the workforce. You know, I even think if we're thinking about data from the most recent PH wins, when you look at the training needs, the top 3 training needs nationally, more training around doing policy and advocacy work cracks the top 3, which is something we didn't see in 2021. So there is a desire to be able to be advocates and to think about the ways in which the workforce can help move forward programs and such that address health equity, because that remains the foundation of the 10 essential public health services and how we keep communities resilient and healthy, and to be able to give them the tools to do that in a way that both protects them in the current climate, but still allows them to do their jobs well.
And if I may, I just wanted to add to your point, Kay, that policy and advocacy work is always about stories.
But here's something you won't find in a spreadsheet: stories. The report argues that if we want to understand health equity, we have to listen to the lived experiences of real people. Community stories, art, even music, these are all data too. And sometimes they reveal truths that numbers alone can't capture.
Anyone who's ever talked to an elected official or they're elected, they're a constituent. It's the stories about your life, your realities, the realities of your community. Those are the things that are compelling. And so I think the other thing that we do in this report is hopefully push our colleagues across public health to understand that stories and narratives are also forms of evidence. They are data themselves. We actually have an organization as part of our Made for Health Justice Initiative, Coalition of Communities of Color, that published an entire report about community data. And community data, as they define it, are data about people's real lives. And those are data that are just as important as any metrics or statistics that we might calculate. Those stories about people's lives, those narratives, those firsthand accounts, but also maps and other forms of art, music that are being created by communities that tell the story of their lives and really convey their needs and priorities. Those are data too. And so I think it's also about pushing ourselves as public health practitioners to expand the variety of data that we see as trusted evidence, and those part of that trusted evidence, that part is stories, and we really should embrace that much more.
So, in wrapping up here, I'd want to pick both of your brains on this one thought I was having as you were going through some of those examples. Is when we think of the current pain points and the way public health leadership is structured or not, which of these recommendations do you think, in terms of adoption, would be the most difficult given where organizations are at right now versus some things that we're doing a little bit better at that might be easier to implement given what the expectation is, if that makes sense?
I think that one that could be very, see, none of them are easy.
None of them are easy. Yeah.
Right. But
Mm-hmm.
I would say the first that comes to mind that is deeply important and truly under the locus of control of agency leaders is to change the organizational culture. I think this is what public health practitioners who are not in leadership positions and that don't have the power to change the organizational culture,
Right,
that's what
right,
they crave.
right.
And that's what we heard. And that's why it's really our first recommendation. It's
Mm.
if agency leaders really believe this work is important, and are committed to doing it no matter what word we use to describe it,
Right,
but they
right,
are
right.
committed to those three elements that Dr. Jones talks about, then there's a way to do it. If there's a will, there's a way. So I would say that's not easy, but man, it's immediately in the locus of control of
Control.
agency leaders
Right.
to change how the health department works, how they choose to partner with organizations, whom they choose to partner with, and to what end. And so I would say another one that comes to mind that could be easy and would definitely be a first step is about the data that we collect and share with communities about health and how it's characterized and how it's contextualized. So no longer we easily have control over the data reports that are written within a health department. Why wouldn't we be more thoughtful about how we're presenting information to make it clear that race is non-biological social construct? We're organizing it this way because we want to show you how the inequities exist and that there are solutions for this. But the other context to add to it, not just numbers, would be stories, information, history, so that people who are reading these reports not only understand what's happening, but why and how and to what extent, and also what solutions might be available that communities themselves are either trying to do or are clamoring for that a health department can be a part of implementing.
Okay. Food for thought. Kay, what about you?
I think Jamila summarized that as always so well, and I agree that this is not easy work, and I think that this is work that takes a lot of time. I think some missteps that are natural and understandable that can happen when you're working in a very fast-paced environment that does have to respond to emergencies and other pressing issues is that there is a culture of urgency and you want results immediately. And I think doing this work is not it's not short term, it's long term, and it's about embedding the practices within culture, as Jamil mentioned. And I think reflecting on what we heard in our interviews, who I would be remiss if I didn't mention, we partnered with Dr. Karen Bell at Tulane University, who's a professor of health equity and public health to help conduct those interviews. I just want to make sure I mention that. One of the things that we heard in these interviews is that even in 2020 and 2021, where others might have been more receptive to talking about this work and engaging in this work, oftentimes employees felt like making a declaration of racism as a public health crisis was really doing lip service. There was no action that followed through with those words, which can help create distrust within leadership and can really situate itself as a point of conflict in organizational culture. So thinking about our context today, having leaders who not only acknowledge that this is important to their employees, but follow through on what they're saying in order to build that trust and accountability is something that can be done and can be built up over time. And also thinking back to what we spoke about previously in terms of communication, really giving employees the time and the space to engage in those processes. So understanding what it means to develop values-based messages and to think about the ways that they are communicating with the public in a very fast-paced environment is one way that all employees can feel like they are messengers and a part of this work and contributing to efforts to address health equity, even if it might be talked about in different language today.
Offering one more chance. Any final words, something that you want to double down on, or something that you wish that you could have said but didn't? Now would be the opportunity for both of you.
I would say, Gordon, just reflecting on how you framed the last question, that infusing equity into the way that we do public health practice is absolutely necessary, not just because it's the right thing to do, because it 100% is, but also it is key to us achieving our public health goals. There is no way we can do our work effectively without a very intentional, thoughtful, consistent, and sustained focus on equity, on valuing all people and populations, on rectifying historic and contemporary injustices, and providing resources according to need. That is our challenge, that is our mission, is to improve community health. There's no way we would be able to improve community health if we're not absolutely zeroed in on what communities need to thrive and to flourish. And so I would say that number one, equity is part and parcel of what we do. There is an array of evidence in the historic record about how public health as a field is founded on social justice.
Right.
Recommend folks read an article by Nancy Krieger from the late 80s about how social justice is the foundation of public health. It's our mission. It's at the heart of what we do. It's at the heart of what we're about. So we have to care about it and we have to do it. And then the second thing I would say is that it takes time, as Kay said. It's something that we have to do. And it is very much possible. It is very much within the locus of our control. Even if you can't control, of course, the culture of your agency, you can be intentional about the community partners that you have at the table, the amount of authority and decision-making power that you give to them, making sure that community residents, especially folks who are working in local public health, there's such a place-based specificity to what is needed to be to make sure that community members and residents are at the table behind the steering wheel making decisions.
Compensation too. Yeah.
Compensation for their expertise, because community members are experts in their lived experiences, and making sure that there's a true partnership and collaboration in terms of how communities are governed and how decisions are made, especially related to the things that we can control in the public health sector. And just as Kay said, it takes time to do this. There is always this perception of urgency. And a lot of times that urgency is manufactured because, yes, public health problems are urgent, but they've also been here a long time. Right. And if we really want to make progress, we have to take the time that it takes to build trust within communities and to do the work right.
Yeah. And Jamila, the only other thing I'd add is that ensuring that all people in all communities have access to high quality, culturally competent resources and care helps people in all communities build resiliency and helps people in all communities thrive. It's not a zero-sum game. And that's something that I think public health folks understand and why we continue to do the work that we do. I feel like at the beginning of this year, we were getting a lot of questions around why should someone go into public health now? Like, why do people want to engage in this work? And the answer is that, like, the problems are still here and they still are important. If not, they're more important than ever. So just reflecting on that as we move into what's next and hopefully get to learn more about what the workforce needs in the future.
So what's the takeaway here? Equity isn't just a buzzword. It's the foundation for public health. The data is clear. If we want healthier communities, we have to make equity everybody's job, not just a passion project for a few. That means changing policies, changing culture, and maybe hardest of all, changing minds. That's it for this episode and for our 3-part miniseries on advancing health equity in public health. If there's one thing that these conversations have shown, it's that real change takes more than declarations and good intentions. It takes listening, partnerships, and a willingness to challenge the status quo. This show was edited by me, Gordon Thane, with additional editing from LaShawn Benedict. Sound design and mixing by myself and LaShawn Benedict. The original music, from The Music Room, composed by Tom Fox, licensed from Johnny Harris. The cover art design for our show by LaShawn Benedict. The Public Health Insight podcast is produced by PHI Media. Thank you for listening to the Public Health Insight podcast, your go-to space for informative conversations, inspiring community action. If you enjoy our podcast, be sure to subscribe and leave us a rating on Apple Podcasts or Spotify. See you in the next one.